Hi, welcome to the first of a three-part series where Dr. Asad Khan and I talk to Professor Carmen Scheibenbogen from the University Hospital Charite in Berlin. She's a long-recognised expert in the field of MECFs and has recently been researching patho-mechanisms and treatments in long COVID. In this film, we talk about the two types of long COVID that were recognised in her paper that was published in Nature Communications, and just how big a role autoimmunity might play in driving the condition. Hope you find it interesting. Professor, thank you so much for joining us. It's an absolute pleasure to speak to you. I was wondering if you could just give us a short potted history of your professional work that's led you to this point.
I'm actually a hemato-oncologist, and clinical immunology is part of hemato-oncology in Germany. And 15 years ago, I became professor for immunology at Charité and became responsible for a clinic for immunodeficiency, special clinic for patients with post-infectious syndromes, mostly MECFS patients. I didn't know much about MECFS before. And I was quite surprised to see that we have a disease which is so severe and frequent, affecting many young people, and we have hardly any idea of the mechanism, and we have no treatment yet. I also tried to connect with physicians and researchers worldwide in the US and also in Europe. Yeah, and then came the pandemic. And in summer 2020, I got already contacted by patients who said they think they suffer from MECFS. So we initiated an observational study. My main interest was to understand in more depth what is long COVID, and also if long COVID triggers MECFS as well. And that's what we've seen over the last 2 years. And what we've learned, sadly, is that not only a relevant number of people who got COVID develop MECFS, but that this is chronic and severe in most patients as well, very similar to what we know already from other viruses triggering MECFS.
Are there any particular characteristics that you've noticed of MECFS that's caused by SARS-CoV-2 as opposed to other triggers?
Yes and no. So the clinical presentation is very similar. We published a paper on this in Nature Communications last year, where we really compared patients who came to our clinic with MECFS triggered by SARS-CoV-2 and by other infections. The difference is more related to biomarkers, because early in the disease, we see a lot of inflammation in post-COVID patients, and we see this in those having MECFS too. And that is more than what we see in MECFS patients not triggered by COVID. But most of these patients we usually see not that early in the disease. So it takes for many patients years until they come to us. So probably what we see here is the early disease course. And that is also an opportunity for us, because now we can study in detail the development of the disease.
In that study, you talked about how there were different groups or different presentations for long COVID. Could you just talk a little bit about what those differences were? One of the things that was mentioned was different levels of post-exertional symptom exacerbation, but what other differences did you see? And do you have any idea about what different pathology might be at play, perhaps?
Inclusion criteria for this observational study was that patients reported that they suffer from moderate to severe fatigue and exertional intolerance, because these are the key symptoms for MECFS. What we learned is that only a subset of these patients fulfills the diagnostic criteria for MECFS. And in Europe, we usually use the Canadian consensus criteria. In the US, many physicians use IOM criteria or site criteria, which are not as strict. But using the Canadian criteria, we had almost half of the patients not fulfilling these criteria, and that was mostly because they had a shorter duration of post-exertion malaise. So in Canadian criteria, it's usually required that when you have a crash, that it lasts until the next day. But we had many patients saying, well, yeah, I have exertional intolerance and I feel worse, but that usually is solved the next day. And we were actually surprised in the beginning to see this, but then we really learned that there are two distinct groups of patients, all having the key symptoms: fatigue, exertional intolerance, pain, brain fog, but different durations of post-exertional malaise. And during the last 2 years, we did various biomarker studies, and we learned that also based on biomarkers, we have distinct subgroups. So probably the longer duration of the post-exertional malaise is important patho-mechanism, which is not active in all post-COVID patients. And for example, we learned that markers indicating hypoperfusion and vascular dysfunction are different in these two subgroups. And we also found that antibodies against so-called G protein coupled receptors, these are, for example, antibodies against stress receptors, that they had different pattern in these patient groups. And this means that if we have elevated antibodies against stress receptors, they correlate with disease severity like fatigue or with hypoperfusion. For example, there are no symptoms. Many patients know that they have cold fingers, which easily turn blue or red. That this correlates with these antibodies. So the higher the antibodies are, the more these symptoms you have when you fulfill the diagnostic criteria of MECFS, but not when you don't do this. So we think it's important to divide between these groups, because otherwise we won't in the end understand which biomarkers are really relevant for disease mechanisms. And we already do this, for example, when we now select patients and include patients for clinical trials. So we do clinical trials, for example, to get rid of autoantibodies. And for these, I think it's important to include, at least now in the first study, only patients fulfilling the MECFS criteria according to the Canadian definition.
On the topic of biomarkers, a lot of people have been to Germany and had their GPCR antibodies tested. Some have sent the samples from abroad to a number of providers. And there seems to be no clear consensus on how to interpret these, because some people will have borderline values, some will have quite high values, but also some people with symptoms that probably aren't very relevant or no symptoms seem to have them elevated. How do you use these in clinical practice?
Well, these are very difficult antibodies, because the typical antibody we do have in autoimmune disease, if it's there, it indicates that it plays a role in the disease, and healthy people don't have the antibody. Here we face a completely different situation, but these are so-called natural antibodies. So actually, it looks as if we all have them. And for example, the antibodies binding against adrenergic receptors, they seem to work together with epinephrine in activating cells and governing the stress response. So what makes them pathogenic is not so much that the level of the antibody, but the function. And we studied this in the past in MECFS patients, and we found that those who have higher antibodies against the beta adrenergic receptor, that the function of these antibodies is lower. That means that in healthy people, this adrenergic pathway is stimulated by these antibodies, and in patients, these antibodies do not work properly, which may result in actually what we see, because the beta-2 adrenergic receptor is an important vasodilator. So that is a complicated system, how we distribute our blood. So we put our blood, for example, in the brain now while we are talking. And for this, we need to dilate the vessels that more blood can flow into the brain. And this is mediated by the beta-2 receptor. And we have an opposite adrenergic receptor, that is the alpha receptor, and the alpha receptor constricts the vessel. And if this interplay doesn't work properly, so in this situation, the beta-2 receptor doesn't work properly, then you may have vasoconstriction or not adequate vasodilation, and that then can result in diminished perfusion. And that's exactly what we see in MECFS patients and now as well in many patients with long COVID. So we think, yes, these antibodies do play a role, but assessing in an individual patient the role of this antibody is quite difficult. The level alone doesn't automatically say that this is a pathogenic antibody, although we think that the higher the antibody is, the more likely it is that it plays a pathogenic role. But the function is important as well. And assessing the function is not that easy. So at the moment, we have no assay which is an assay which can be used easily in routine application. But there is more and more papers now showing that at least in MECFS, these antibodies do not only correlate with symptom severity, but also with objective markers. It's a Japanese group showing that elevated beta adrenergic receptors do correlate with certain changes in the brain structure. There was a very recent paper also showing again that it's associated with hypoperfusion of the brain. So that fits very well into our concept. On the level of a single patient, these antibodies are not of such a diagnostic value as, for example, antibodies against double-strand DNA. Then this is a highly suspicious diagnostic test that a person suffers from SLE. And from an elevated antibody against beta-2 adrenergic receptors, we cannot conclude that this is an ECFS patients or long COVID patient. We find these antibodies, for example, in asthma patients as well elevated, or in patients with cardiac arrhythmia.
Hope you found that enlightening. The next film in the series will cover Prof Scheibenbogen's thoughts on viral persistence and how you'd go about treating autoimmunity in the context of long COVID. Film 3 will address how long treatment trials are likely to take and just why getting good research done is so hard and takes so long. Look after yourselves. Until next time.